We can get started. I hope and suspect we'll have more people joining. Melinda, as people get out of clinic, sometimes people are joining, but we're still all looking forward to your talk. So it's my pleasure today to welcome and thank Dr. Melinda Mushonga for speaking today. Melinda is an early career clinical oncologist who completed her medical training, including a residency in radiation oncology at the University of Zimbabwe. And she attained certification as a clinical oncologist in February 2020. She then pursued a clinical fellowship at Princess Margaret Cancer Center and is now at Sunnybrook in Toronto, my old alma mater, with the lung site group and some of my colleagues, some former colleagues there. Her research interest is advancing the evidence base for personalized treatment strategies in radiation oncology, guided by tumor biology with the goal of improving patient experience in breast and lung cancer treatment through inclusive collaborative clinical research, which promotes equity and quality cancer care, narrowing disparities in outcome. Making clinical research accessible to Zimbabwean women with breast cancer is one of her career goals. Foundational research work with accompanying publications completed in Zimbabwe explored patterns of care in breast cancer management from a low resource setting to guide future work that closes the gap in cancer care. Dr. Mushonga is a member of several professional society groups, including Aortic, ESMO, CARO, and others. She's actively involved in the Cancer Serve Trust on a volunteer basis, a charity organization which assists in lobbying for funds for care supplies for women affected with breast cancer. Welcome, Melinda. And I think one of the great things is we met you at the Canadian Global Oncology Workshop, which Queen's Global Oncology Program hosted. And it was great to meet a number of colleagues across Canada. And you were kind enough to agree to come and speak at our Global Oncology round. So thank you very much. One question before you start speaking is, one of the professional society groups you belong to is called ARROZ, A-R-R-O-Z, and I tried to look that up and I couldn't even find it on the internet. So maybe I'm interested in finding out what that is, and then I'm looking forward to your talk. Thanks very much.
Thank you so much for the kind introduction, Dr. Berry. So ARROZ is the professional organization for oncologists in Zimbabwe. So it combines like radiologists and clinical oncologists. So we are all under that board. So it's Association of Radiologists in Zimbabwe.
Okay, that's perfect. Mm-hmm. Thank you very much.
So I will start my screen sharing. I'm hoping everybody can see my
looks great.
Slides. Okay, good. Let me just So my presentation is essentially summarizing some of the work that we have done back home in Zimbabwe on breast cancer, and possibly a bit on one ongoing project. And within that presentation, I also intend to give some clarity on some of the challenges or some of the things that we encounter when you're managing breast cancer patients in Zimbabwe, which is a typical low middle income country. So my outline will be as follows. We will briefly just discuss the demographics of breast cancer in Zimbabwe, oncology facilities available in Zimbabwe, the breast cancer research, then we go into the patterns of care, understanding the challenges, and possibly discuss what next. And based on everybody's experience, I think it will be good to just discuss and offer each other ideas going forth. I have no pertinent issues to disclose, and this presentation expresses my opinions, and I do not represent any company or organization on this presentation. So Zimbabwe is a country which is in Southern Africa. It's a landlocked country with Zambia, South Africa, Botswana, and Mozambique, sharing borders with those 4 countries. Estimated population is 14.86 million, and 9.5 million people live in the rural areas. But of note is that as of 2019, regardless of one's location, 72% of the population is estimated to live under the poverty deadline. When we dwell into cancer demographics, the last statistics that we have that are published are from 2009, of which there were 3,519 cancer cases, but I strongly believe this is an underestimate. And of those, about 60% were women, and the second common was breast cancer. This is an extra that I took from GlobalCare in 2020, but just looking at the figures, they probably used the information that is available from the 2009 statistics, where we can see breast cancer as number 2 when you look at all sexes, regardless of all sexes. And when we look at females, it also comes second to cervical cancer. So in Zimbabwe, we have 2 public oncology facilities with RT radiotherapy services. One is in Harare, which is the capital city, and the estimated population is 1.5 million. And the second facility is in Bulawayo, and the estimated population is 640,000. We have one other public hospital with facilities for systemic chemotherapy only, that's Harare Hospital. Now it's now known as Salim Mugabe Hospital. And we have one private facility that has radiotherapy services, it's also in Harare. We have 10 private clinics in Harare, which offer oncology services, the systemic therapy administration and overall clinical care. And these are run by practicing clinical oncologists. And we have 2 such clinics as well in Bulawayo. There's a total of 6 linear accelerators, 3 are at Paringatwe in Harare, the public institution, 1 at the private institution, and 2 at Mpilo in Bulawayo. There are currently 12 practicing clinical oncologists in the country. And there is an established residency program which has been running since 1990, of which the total number of graduates is 26 based on a paper that we wrote with Dr. Ndlovu, who's the program director. And of those 26, 7 were from other African countries back then in the 90s. I think the last time we had international residents was 2020, we had 1 graduate from Malawi. We have an established oncology nursing program and a radiotherapy for RTT's training program as well. So back in 2018, Dr. Shekina Elmo set up a Harare breast cancer study group after she applied for a grant when she was still like a resident at Harvard Medical School under the mentorship of Dr. Anna Mary Nyakaba, who's one of the established clinical oncologists in Zimbabwe. So she had a grant, came over and set up the study group, which I then joined in 2019. After realizing that breast cancer is understudied in Zimbabwe. There's more focus on cervical cancer because it's the #1 priority, because there's a high incidence of HIV in Zimbabwe. So this group is supported by University of Zimbabwe Research Support Unit. They manage all financial aspects of any active grant that may be available. And we do have a dedicated financial administrator. Currently, we are 3 doctors, and we had 1 research assistant. She just left last year for the UK, but we are looking to engage another one if we do have another active grant which is awarded. So we have looked at 3 projects to be precise, and I will start with the first one and summarize what the findings were. So the first one, we looked at patterns of care and adherence issues at Paringatwe Hospital, focusing on patients who came to the institution from 2014 to 2018. So we wanted to understand the patterns of care, adherence patterns for women in our country, and possibly offer a perspective of what could be, the situation in the rest of Sub-Saharan Africa in places where there is radiotherapy access. So ultimately, there were 361 patients who met our study criteria. Median age was 51.3 years. 14% were HIV positive. Only 21% had health insurance. And of note, 70.7% patients did not have hormone receptor status at diagnosis. The majority of patients were from Harare, that's 56%. And the majority, about 2/3, did present with a lump at presentation. So when we looked at the patterns of care, we noted that there was a 12.6% loss to follow up after the initial visit. These are patients who would come for the initial consultation. And most of the time we get patients, like when the patients come, they usually come with biopsy results and that's all. So from that initial consultation, we do then request the workup, investigations, blood work, imaging as necessary. And so from that group, 12.6% did not come back. So for those who did come back, 56% had locally advanced non-metastatic stage, and 43% had metastasis at initial presentation. Of note, only 19% received neoadjuvant chemotherapy and 64% had initial surgery as part of the treatment plan. And for 4% of patients, we couldn't establish like which came first, like the order of treatment. Only 34% of patients were eligible to for radiation, received radiation. We later on looked at how the trends were in terms of completing planned treatments before 2015 and after 2015. Why 2015? Before 2015, there was a little bit of economic stability in Zim compared to after 2015. So you note that the darker bar graphs represents, treatment that was completed during that time when we didn't have, when we're having economical challenges. So what we concluded from this study is that radiotherapy was underutilized by patients with breast cancer, despite it being available. And we also noted that exploring this patient level factors could better enlighten us on issues to do with adherence and also offer better tools to support adherence and improve survivals. And we also noted that a greater investment is needed in multidisciplinary care of breast cancer in sub-Saharan Africa. Our second project was a prospective study. We were estimating baseline lymphedema using a circumferential method in women with breast cancer. So we wanted to provide a concept of a simple low-cost lymphedema measurement and to estimate the baseline lymphedema prevalence. And so we took baseline measurements with a validated segmental circumference method 2, and translated these volumes using the contrast approximation. So we had complete records for 27 of the 29 patients when we did the interim analysis on the abstract that we presented at IOTIC in 2019. Median age of patients was 50. And in 67%, there wasn't any evidence of lymphedema, and 22% had subclinical lymphedema, 11% had clinical lymphedema based on the criteria that we used. And there wasn't any significant difference between preoperative and postoperative status. And self-reported arm and hand swelling did not correlate measured volume, but did correlate with self-reported social challenges related to illness, because we also had a patient-reported outcomes components to the study. So the conclusion that we had from this project, we noted that estimated baseline lymphedema was 11 to 33%, and we are still analyzing the last, the full cohort, because this was based on the first 29 patients. And that measuring with the simple 2 was quite feasible in this in this low resource setting, and that we should be able to to institute lymphedema measurement is something that is consistent during follow-up, because when we did this, it wasn't something that was part of the follow-up strategies. So our ongoing study currently is we are looking at the prevalence of triple negative breast cancer and clinical outcomes for patients who are HIV positive. And we are hoping that from these results, they may lead to the development of tailored interventions to improve care for women who are HIV positive. And this can also be tested in future multi-center randomized clinical trial. So we had delays during COVID. So currently it's the pathology, which is still ongoing. On the stains for the previous slides that we had for the patients who met eligibility criteria. So I aided this project, which was part of my dissertation when I did my residency. I looked at biomarkers in breast cancer and looking if there was any discordance with best practice when patients were managed without hormone receptor status. So the findings from that study, I noted that there was 67% of patients who did not have hormone receptor status. That was between 2014 to 2016, which is in keeping with what we found from the larger retrospective analysis that I just described, whereby it was around 70%. And that treatment approaches in general, when we look at the planned treatment plan by the treating physicians, we're largely in agreement with the NCCN guidelines for stage 1 to 3, but there was discordance in stage 4, whereby we noticed underutilization of hormone therapy as initial treatment. So what are the challenges that we have encountered from my perspective, in this, with my exposure to research in general? There's limited mentorship on clinical research, something that I realized in this collaborative partnership, where I learned a lot. And unfortunately, when you look at eligibility criteria to apply for meaningful grants that cover all costs that that are encountered in a low middle income setting, you don't find much. And when you look at the budget and looking for trying to complete the salary support aspects, these budgets are like in US dollars, and they will require, in most instances, that you divulge like in terms of how much you're earning, but they're so unstable in exchange rates when I'm looking at Zimbabwe, such that it's very difficult to actually justify a cost of, a salary that actually, is meaningful for cost of living. And most patients in general do not meet eligibility criteria for prospective trials. So when you do have ideas and you're looking at, okay, fine, what are the minimum requirements for me to complete this trial? Most patients will not. It's difficult enough to actually establish the stage. And therefore this limits in terms of what we can do, what you can do when you look at prospective trials. And as I mentioned earlier, the limited collaborative partnerships, currently. So why do I think research should be supported in low middle income countries? Research guides local practice and policy. One of the issues that may stimulate change is having conversations with politicians, people who implement policy, but you need evidence to present, and that only comes from research if it's fully supported. And collaborative platforms that can be established during research can actually be a platform to learn. And it also enables access to new medications. And it's also an opportunity to even study local medicines and how they can be introduced to practice if relevant. So to better understand the challenges, I thought we should just go through the processes in terms of what workup involves and what is encountered in low middle income settings. This is the typical picture of most patients that we see. They come with, fungating masses, local advanced stages, because there's so many myths and misconceptions that actually, result in such delays to treatment. And there are also structural constraints, as I highlighted earlier. We just have, oncology facilities in capital cities and none in most provinces. And patients have to pay out of pocket to actually go through the entire workup and treatment. And there are also many other social cultural factors in uptake of breast cancer. People link it to witchcraft and many other things that also result in further delays. So when you look at the NCCN harmonized guidelines for breast cancer, the minimum standard is, after making the diagnosis, which includes a biopsy, it's also recommended that you have hormone receptor status and imaging, ultrasound, chest X-ray. And when you look at, most of the patients with T4 tumors, they require imaging. So at the end of the day, it's almost all patients require some form of imaging before setting up a treatment plan. So when I drove back into the workup, because the practicing environment has a private system and a public system, when you look at the initial blood work, in private, total cost is around $100. I put in US dollars because most of the services are paid in US dollars back in Zimbabwe. Public is about 50. CT, chest, abdomen, pelvis, 300 to 500, depending on which place you go to. Ultrasound scan, chest x-ray, 100, biopsy, 90. So you find most patients have their biopsies in private most of the time. And biomarkers are also done in private, whereby it's $50 for each stain. So that's $150 in total. So just for the workup, a minimum of $650 to $840 in private, and in the public, about $390 US. When you come back to systemic chemotherapy, I was just looking at ACT, which is the common chemo combination for most of our patients. In public, the total cost would be $1,048 estimated. And in private, when you look at patients have to pay for the medication, they pay for the doctor's fee, and they also pay for the facility fee. So the cost would then come back to anything between 2.8 to 3.8. Radiotherapy in the public sector is around $300 to $400. And when you look at the cost in private, there is the cost for the private, at the private facility, it's about $3,000, and doctor's fees anything between $2,000 and $3,000 US to make a total cost of $6,000. Surgery, I couldn't get the estimated figures on time, but I'll put it at 400 just for the purposes of this discussion. And in private, I got a round figure from colleagues, and they put it at anything between 4,000 and 7,000, because you have to pay the surgeon, you pay the anesthetist, and then you pay the hospital fees. So when you look at the total cost in private, we're looking at something like 13,000 US dollars, and in public, 2,500. And of note, I didn't even include, Herceptin for patients who are HER2 positive. So what next? I think the initial stage is acknowledging the challenges, of which I think most of us are all aware of, delayed diagnosis, and at times really incorrect diagnosis, and a huge factor, financial, and there's also a component of ineffective treatment, which is poorly studied in this setting. So what are the proposed recommendations? We need to keep on consolidating awareness programs to ensure downstaging and presentation, engage political powers, as I mentioned earlier, so that at least it begins with equity in cancer care within countries. Support clinical research. These findings can be presented to politicians or other people who may have, influence. Targeted educational interventions based on findings from research work. So this could include, if we note patients from a specific region are probably presenting with more advanced, we then engage provincial hospitals, teach healthcare workers, village healthcare workers in terms of, more education, like on cancer and why early treatment is important, and, give hope, like in terms of outcomes associated with early presentation and early treatment. There's also an issue of exploring the role of patient advocates in sub-Saharan Africa. There's a study that I recently did and presented at ESTRO that looked at hypofractionation in breast cancer patients. And one of the findings noted that in terms of patient engagement in low middle income countries, it's not something that is very common. So you find if we can explore more, like in terms of, establishing patient advocates in these regions that can assist in, let's say, for example, if discussions on radiation therapy are being discussed, things like hypofractionation can also be considered in patients who meet clinical criteria. We may also need to engage awarding agencies, like in terms of people who kindly provide grants to revisit eligibility criteria for low middle income countries. You find for most, there is a requirement for, completing a PhD, doctorate, and there isn't much opportunities to actually do that. So at the end of the day, it can be demoralizing, like in terms of you rarely meet any criteria for any of the meaningful grants that could be available. And I find grant writing and formal research methods something that is vital. I appreciated it, especially coming over and being exposed to so many grant writing and formal research methods, training that, there's so much that we still need to do back home. Salary support protected time should be flexible to consider economic dynamics of low middle income countries. Mentorship is very crucial. And the last point, I'm not too sure, that's why I put exclamation marks, like in terms of including wake-up cost in funding, but you then also ask, when you look at ethical considerations, when you're looking at consent, you wouldn't want a situation whereby it's, patients will be forced to commit to a study just because it's going to be, they're going to be funded. Treatment is going to be funded. So it's one thing that we need to really look at and discuss and explore. This brings back to my conclusion, and I'd like to acknowledge Dr. Shekina Elmo, Dr. Anami Nyakabau, who's provided very sound mentorship, and the rest of the breast cancer team. Dr. Ndlovu, who's the program director from UZ, and colleagues back home. I reached out to them to just get updates on cost of care, and the University of Zimbabwe for the research support that they continue to grant. Thank you.
Well, thanks so much, Melinda. That was an incredible talk. And thanks for sharing that. I actually have a lot of thoughts and questions, but maybe I'll open it up for the rest of the group first. John, go ahead.
Thank you. That was really a good talk. It's good for us to hear some of the challenges that folk have. When you're talking about the granting agencies, what are the agencies that you're approaching? Who are you trying to get some of that funding from?
So one of the platforms that I really find useful is ASCO. I think ASCO is doing like a great job, like in terms of trying to, make sure that research is something that is, supported. For example, when you look at the recently introduced breast cancer grant for, diversity, inclusion, one of the things is for you to be eligible, you have to be in a fellowship. This is not something that is available back home.
Yeah.
When you look at the grants from, I always get pop-up messages from Pfizer, many of, good things, you have lots of ideas. One of the things you say, do you have a PhD? I don't. And this is the time I have the most energy. So you literally go back and forth, and you spend so much time just trying to find grants that you can qualify for.
I'm a medical physicist, and I hear the same concerns from my colleagues in Africa right now, because very few of them have PhDs. In fact,
yes.
often they don't even have a recognized master's degree, and they're saying, how can we apply for some of these?
You can't.
Yeah, it's a struggle. I think we have to start advocating support streams if we're going to be serious about this.
I agree.
Thanks, John. Any other? Maybe I have a. So one of the thoughts I had, Melinda, is you talked a lot about the challenges of doing research, and yet you presented a lot of excellent projects. So I'm wondering, despite the challenges, what are the enablers for you? Apart, I imagine, I just having met you a couple of times, personal energy, enthusiasm, etc. But what's been you've done some great projects. So what's been your path to get that done?
So in my acknowledgements, I included Dr. Shekina Elmo. She established this partnership. So it's more like a collaborative setup. All those projects were through grants that she managed to apply. She was eligible for them just based on location. So this has been the primary, funding to be able to actually do this. The only other project that I presented that wasn't part of that is my dissertation, which was part of residency. So this has been enabled through collaboration, to be precise.
That's great. I'm sure a lot due to your own perseverance. It's actually a small world. I think our colleague Nazi Kamad is actually in Zimbabwe right now at the end of her sabbatical. So probably visiting with. We've worked with. I did a aortic presentation with Ntakuzu for education. So I'm impressed what she's been able to do in the training program. I guess the other question I had for you is on the first study, and it came up later in your presentation, was getting better access to care for women with breast cancer and just the role of primary care. And you brought that up later. In Canada, with as you know now, screening, and probably people enter more through screening and surgeons, but how are primary care providers involved and just you talked about engaging primary care providers. Any other? I'd be interested in hearing a little more about that.
Mm-hmm. So the challenge has been, as when I graduated, like from medical school in 2010, oncology was not part of the curriculum. That's like 2010. That's like 10 years ago.
Right.
When I did my internship, it was during my general surgery rotation, and I just become a mom, that I would see young mothers with breast cancer flagellated masses. And I remember I really wanted to be a surgeon. I actually was like a government medical officer for 2 years in surgery, doing toilet mastectomies, but everybody would die. So I then asked myself, I didn't know much about oncology. I'm a doctor, graduated, internship just done, but I don't know much about oncology. Then I asked, is there anything that we can do? That's when I realized that there was an oncology institution, because my internship was at another hospital. I remember driving there one afternoon because I had heard that one of my colleagues had started residence the previous year. So I went looking for her and to get to know what this, department does. I spent the afternoon there, and that's when I applied to actually start oncology. So this is my experience, whereby it was only around 2014, 2013 that I got to know a lot, to have some understanding regarding oncology. So you can imagine every other people who we have graduated earlier. So we are still at that phase whereby, okay, fine. How do we then engage? How then do we, start, having educational interventions for practitioners who are already in practice? I think that's where the challenge is in terms of time and funding, because at the end of the day, when you're back home, you're also taking care of your family. You are working in private to be able to sustain your family. So balancing that in doing this other aspect requires a lot of commitment and sacrifices that may be challenging. So I still feel that, yes, engaging primary, healthcare workers is something that is very crucial. And we are still at that stage whereby we still need to, sit down and hopefully find ways of engaging, primary healthcare workers to assist in terms of education and screening and, all that.
Thank you. That's a very interesting story in that you found oncology, as it was developing. Oncology. Yeah.
But it's now in the curriculum as of, I think, 2-3 years ago. Dr. Ndlovu really pushed, which is something that we are grateful for.
Yeah.
So the new graduates, I think, yeah.
That's good, considering it's, given how common it is. It's interesting, even in Canada, in undergraduate education especially, it's still a struggle to get oncology into the, even despite how common it is. Any other questions for Melinda? And if not, I just have one more question, which is, you know, in terms of getting back to the issue around breast cancer, what do you think would be the single most effective, change that could happen, to improve care for women with breast cancer? Is it, local education about breast cancer, screening program, access to surgery? Where would you focus your efforts?
I don't think at this point in time, even though screening is important, I don't think screening is like the biggest priority at this point in time. Why I'm saying so, like having practice in that setting, most patients present late. When they present late, they already have, inferior outcomes. So the people around them then associate coming for treatment with early death, not realizing that, it's actually the late presentation. So I would prioritize education and access to care so that at least the patients who actually have breast cancer already get treated. And when they get treated, they're the same patients who can actually go back to communities and become patient advocates. So it will be like a reversal to the traditional, screening. Of course, everything is, important, like in terms of attending to all those facets. But right now, access to treatment, education are the most crucial, according to my observation.
That's very interesting. That makes a lot of sense, though. So I would just see if there's any more questions.
Could I just ask a brief question?
Yeah.
Melinda, thanks so much for that talk. It kind of brings back quite a bit of memories. I actually grew up in South Africa and did my undergrad in Durban and have quite a few friends in Zim. I remember taking a road trip and we ended up going to, is it Mutare or Masvingo instead of Harare?
Yes.
We took the wrong turn and it took us quite a few hours to get back to where we're supposed to go. But yeah, thanks so much for that. I was just wondering, so in terms of your training for radiation or clinical oncology residents or registrars, depending on what you call them, how many a year does Zimbabwe produce? Because you only mentioned 12 oncologists for the whole population, so that's over 1 million per person in terms of how many you're looking after. Is that right?
Yes, okay. That's a good question. So you find oncology wasn't like a popular program generally. Yeah. As from my encounter, it's something I found oncology based on my experience. So it's one of those specialties whereby, unfortunately, back then, people were not really enthusiastic. So based on a paper that we wrote with Dr. Ndlovu, she did most of the research. Like she was summarizing in terms of how many residents have been produced since the inception of the program. That's in 1990. There's been 26 graduates from 1990, of which 7 were non-Zimbabwean, so they returned to their countries. They just came for the training and went back to their countries. So that leaves 19. Of the 19, 4 are practicing out of Zim. That leaves 15. And currently, 1 is retired and 2 are entirely private.
Okay, wow. And in terms of residents, how many do you have in training at the minute?
So in training, because of COVID, there wasn't an intake last year, but I hear this year there is an intake for people. I'm not too sure if they all came, because in my group, we were 4 initially, but I graduated alone. I was the only one by the end of, the second year. And in terms of the other ones at different levels of training, they're 5.
They're 5, okay. And do you think that, you're obviously gaining quite a lot of experience from your fellowships in Canada. Do you think that there is perhaps an untapped potential resource that countries such as Canada could help with when it comes to, you're talking about increasing research, grant writing, that type of thing? If there was a more streamlined pathway for residents in your setting to come across a year or two, gain a lot of expertise, and then go back, set up projects or continue on, or maybe even potentially look to doing MPHs, PhDs, and those types of things. That's something that's been thought about. That's just my last question.
I'll be honest, I haven't had like any discussions with anyone like in terms of that approach, because I probably just came here soon after I completed my residency. I probably worked for like a few months, but I agree it's something that actually should be strongly considered, especially, beginning as, collaborations, virtual, educational sessions on clinical research and, research methods right at first year. And along the way, we can actually consider, some form of, skill training exchange to also enhance, clinical skills to, complement the training that is available back home.
Okay. All right. No, thanks for that.
So Melinda, thanks for taking the time. We met at the Global Oncology Workshop. You're kind enough to speak today. Please, let's keep in touch. Because I think that we want to make sure we already have connections with some of your colleagues, and I think that working together to meet your needs and think about how we can create some of these or address some of these issues around capacity building, grant writing, and opportunities for funding for research. Let's try and continue to work through those together.
Thank you so much for having me.
Yeah. Great presentation. Thanks again. Thanks, everybody.
Thank you.